Hi everybody, welcome back to the channel. My name is Drew. I'm an accredited exercise physiologist and a registered Chinese medicine practitioner with over 20 years of clinical experience. And I work really in this kind of space where I combine modern kind of Western exercise rehabilitation science and ancient wisdom of the movement arts, particularly Tai Chi, yoga, Qigong, pranayama, particularly the movement process I really love to integrate. And currently taking a PhD, and I'm studying various aspects of breathing protocols for health conditions, which is super fascinating. But in today's video, we're looking at the ligaments of the shoulder, building up our knowledge of functional anatomy, which helps us prescribe exercise, understand exercise, and help our clients move well, feel well, and just perform better. And always good to kind of just kind of appreciate what a ligament does. So ligament, the root from ligament comes from the Latin ligare, which means to tie or to bind. So ligaments' roles are really just to keep the bones in the right position during movement so they don't dislocate. So when a bone moves out of alignment too far, it's classified as a dislocation. And if you've ever dislocated your shoulder or your knee, you'll know how that feels. It's very, very uncomfortable. So the two most common joints to dislocate would be the shoulder and the patella. I also have a friend of mine who has dislocated her elbow, which was incredibly painful. It's very, very hard to dislocate your elbow, but if you fall the right way, it can just leverage the bone and pop it out of the socket, so to speak. So dislocations initially are really quite painful. Repetitive dislocations, often what happens is the ligaments around the joint become stretched or lax, and so they no longer kind of tie or bind the bones into the actual joint itself. So then you get instability. So once you have instability in a joint, then the muscular system around the joint has to compensate. So a lot of the stabilizer muscles and synovial muscles tend to have a greater stability role. And that means that they often become very short and tight to kind of keep the bone in a position. And sometimes the bigger movement muscles also take on that role as well. So then you lack movement and mobility because the muscles are trying to maintain joint integrity. So you lose that kind of capacity. With surgical interventions, surgeries are getting a lot better now. So with right surgery and good rehabilitation, you can often restore joint to a very, really functional level. Typically, you'll lose a little bit, but you can really get back into most things, depending on the severity of the dislocation and the rehab and type of surgery and all those kind of other factors. So in today's video, we're going to explore the biggest ligaments in the shoulder. And we're going to start with the synovial capsule. So if I come over here onto the right side and we just hide that one, the first thing we have here is the synovial membrane of the articular capsule of the glenohumeral joint. So the synovial membrane is basically it's connective tissue that encapsulates the joint. So it goes from the humerus, your arm bone, to the scapula. So the actual bones themselves are encapsulated within this synovial joint. So if I remove the synovial, there you can see then that we have the actual joint itself. So the shoulder joint or the glenohumeral joint is the humerus and the scapula. And this part in here is called the glenoid cavity. So that's where you get glenohumeral from. So it's the glenoid cavity, that part on the scapula, and the humerus here, so glenohumeral or shoulder joint. Most people just refer to it as just shoulder joint. So if we're going to return the synovial fluid back, not the synovial capsule, so that's going to basically protect, encapsulate the joint. And when you do movement, the movement that which gently stretches and mobilizes this tissue promotes the secretion of synovial fluid. And that's the joint lubrication. So gentle movement is really, really good for joint health and bone health. So practices like very gentle yoga or Tai Chi or gentle mobility exercises are really orientated around optimizing the health of the joint, and by one mechanism by increasing this secretion of synovial fluid, which is like the oil of the joint, it keeps it lubricated so it can move. When you're cold, when you have been not moving for a long time, so imagine you being on a long haul flight and you've been sitting down for a long time, because it's not movement, you're not secreting the synovial fluid, and so the joint tends to get a little bit stiffer because you just don't have that lubrication. So gentle movement is really, really good. So it's one thing you want to do when you're going on a long trip, when there's a lot of sitting involved. Wherever you get the opportunity, get up and move around and just gently kind of move your body any way you really want to that feels comfortable to get that kind of promotion of that synovial fluid release. Then if we put the gotta undo all those movements I was just doing. We'll bring back the articular capsule. There it is. Okay. And as always, guys, we're using the 3D for Anatomy or Complete Anatomy app. There'll be a link in the description below. So jump on there and grab a copy. It's a really great learning tool. Then we have the fibrous layer of the articular capsule. So this is the thicker, stronger connective tissue, really strong collagen fibers. So most ligaments are predominantly made up of strong collagen fibers. So really, really strong, great tensile strength, but don't have a lot of elasticity, don't have a lot of elastin in them. So they're designed to be strong, but not flexible. So this fibrous layer wraps around the entire shoulder joint again. So giving that really nice, keeping the shoulder nice and snug in the socket, if you will. Then if we shift over to this side, let's remove that one. Then on the anterior aspect of the glenohumeral joint or the shoulder joint, we have the anterior ligaments. So we have the superior glenoid ligament. Then we have the middle glenohumeral ligament, which means then we're going to have a inferior glenohumeral ligament, which is quite a big one, kind of wraps right around to the back. So we have superior, middle, and inferior glenohumeral ligament. It's kind of almost like another articular capsule. And then on top of that, we have the coracohumeral ligament. So this one goes from the top of the humerus onto this bone here, this kind of green part here. This is the coracoid process. So it's going in deep into the coracoid process. It's kind of underneath the clavicle, so a bit difficult to kind of access. The superior glenohumeral ligament goes from the anterior aspect of the bicipital groove coming here. So these two kind of ridges, that's the bicipital groove here. So this is the anterior aspect of that. And again, then it's going attaching onto, this is the scapula, and this is the kind of almost the rim of the glenoid capsule here, or the glenoid fossa. So it's kind of attaching on the inside of where the glenoid is. And same with the inferior one, the medial glenohumeral ligament. And then the inferior one is, again, it's kind of like tracing the actual shoulder joint itself. So here you have quite a lot of stability on the front and underneath. So that's going to prevent the shoulder from going forward and going down and going up. But there's a little bit of a weakness here at the back. So then the shoulder can pop out posteriorly through here. So you can get dislocations in both directions. You can get a posterior and inferior and anterior. It just depends on the angle of the arm and how people land, or where the leverage is coming through, and you can pop out. Some people naturally have slightly lax ligaments as well, or if they've been doing, for example, a lot of yoga. And one of the problems with yoga asana particularly is you get into a posture or an asana in yoga, and then you're told to hold and relax. And so people can, over time, really take their joints to the full end range and then fully relax. And so the muscular system is not stabilizing as much. and it puts all the load onto the ligaments. If done well over a long period of time, it'll strengthen ligaments, but if it's pushed too quickly, too fast, it'll essentially start to overstretch these ligaments and they lose their kind of stabilization role. So unfortunately, I do know a lot of yogis who have shoulder issues, knee issues, and hip issues because they've overstretched their ligaments. Not just a yoga thing, but because that yoga set a kind of combination of you want to be able to relax, you're doing long, slow, deep breathing, and you're holding, and with the incorrect instruction, then people can like rest on their joints and they get overstretched their ligaments, which is not what we want. Then we go into this little ligament up here, the Coracoacromial Ligament. So coracoid process is this kind of part of the scapula here. And the acromion process is this flat bony part here on the spine of the scapula. So coracoacromial ligament, keeping those two bones in nice position. And then we have underneath the coracoid process here, we have the trapezoid ligament, which is essentially going from the clavicle in a kind of trapezoid shape to the coracoid process. And then we also have here the acromioclavicular ligament, or the AC ligament. So this is the big one you'll see in a lot of contact sports where you get shouldered and this ligament can get damaged, and then you'll have, instead of being a smooth kind of ridge along the front here, you can kind of palpate there's a drop. So some people naturally have a drop. It's just as the clavicle and the acromion have kind of fused together. They may have fused in a slightly different angle, but typically it's one way you can quickly diagnose or see if someone's had a shoulder problem. The plastic, but those big kind of step drop down through this region here. This is a really important ligament. This one's unstable, essentially, because this connects the clavicle to the shoulder blade or the scapula. So it's a really important weight-bearing ligament. And so if that one gets damaged, essentially the whole shoulder doesn't work very well until it's fully healed up. And I have worked with some clients in the past who've had AC problems, and it just for whatever reason, they didn't respond to the surgery and they just had ongoing shoulder problems. That can be real painful. The pair one to that is the anterior sternoclavicular ligament, and there's another one posterior. So the SC joint, which is the sternum and the clavicle. So the SC joint is technically the only joint in the body that connects the arm to the torso. So this joint here is really, 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 really strong. And I actually managed to injure this joint. I was working way back in the day in a factory, literally packing and stacking boxes on pallets. So working in a McCain's factory, where they make all the dinner meals. And if you worked in one of those factories and you've seen how they process food into those dinner meals, you'll never want to eat them again. So I don't think I've ever had like one of those preheat dinner meals ever. They're just, yeah, you don't want it. Anyway, so one of my jobs was at the end of the line, when they're putting them all in the boxes, I would then get the box off the conveyor belt and stack it onto a pallet. And you do that for essentially 8 hours. So lots of repetitive lifting. And there was one particular meal which was heavier than the other for some other reason. And I was doing this for a couple of weeks, and then doing that same job, I managed to strain this ligament here. It was quite painful for a long time. And the way I rehabbed it was, once the way I figured out what it was, actually went to a chiropractor. I had a good chiropractor. She diagnosed it for me. And the way to kind of resolve it is you want to promote that mobility in the tissue. So it's just very gentle palpation on there to promote that synovial fluid release. So then the structure can heal. Of course, you've got to rest it. And then, so that was the kind of how to fix the ligament and decrease the inflammation, swelling in through there. Lots of gentle mobility work in the torso, in the shoulder, and the arm. and then gradually building up the strength in the whole upper body as well. And then the last piece was correcting my poor lifting technique, which I didn't realize I was doing, but that was big contributing. I was holding boxes out from my body instead of close, and that was putting more pressure onto that ligament. So just a little kind of personal experience there. So that is the only point in the body where the arm attaches to your torso. So it's a really important joint. So you want to look after it. It's quite hard to actually injure, quite hard. Me being me, I managed it. But if you look at the shoulder blade itself doesn't actually physically touch the rib cage, because underneath the shoulder blade, you've got the serratus anterior. So there's muscles, and you've also got the subscapularis muscle. So you've got two layers of muscle that sit between the shoulder blade and the rib cage. And so you're not going to actually connect the shoulder blade to the ribs. So then you've got the rhomboids and the trapezius, serratus anterior. They're all connecting the shoulder blade to the torso and to the ribs via the muscular system, but there's no actual articulations, no bone to bone, because you want that shoulder blade to be able to move and slide on the back of the rib cage there. So that's super important. So one of the key ways, while we're on the topic, if you want a healthy shoulder, you want to focus on anterior. This muscle, look how big this muscle is here. This is the serratus anterior. This is your punching muscle or your push-up muscle. So when the arm's out straight and you go further forward, so that's protraction. So if you can get that muscle working really well, it essentially attaches onto the anterior aspect of the scapula, and that'll keep it nice and snug on the rib cage for you. So if you can get that bad boy working really well, and then some rhomboids. Rhomboids here, and then some trapezius. Trapezius, so you get those three muscles working properly, you'll get a really good, healthy, stable shoulder. So you serratus anterior gives you that kind of anterior stability. Traps give you superior medial and inferior stability. So down, up to the middle, and then you've got the rhomboids on the inside, which gives you that that kind of middle stabilization through here. And that will give you what's called scapular stability. And if you have scapular stability with the muscular system, then the pressure on the ligaments will be evened out. And so you won't overstress, oversprain ligaments with movement. If you dislocated your shoulder, you must get these three muscles working really well. Big mistake people make in shoulder dislocation is they focus on the rotator cuff muscles. So like your supraspinatus, your infraspinatus. Now, if you look at the size of, say if I put in infraspinatus, or supraspinatus, which is the one that everyone seems to obsess about. So the job of supraspinatus is to when, if you follow the line of pull of the muscles here, it's going to contract and pull the shoulder into the socket. So it stabilizes that, and also has some abduction movement because it's going to pull this way, which will bring the arm out into abduction. It's primarily to stabilize the humerus into the socket. Now, if you look at these huge muscles here, they're bigger, they're stronger, they're attached onto a greater aspect of the actual shoulder itself. So that they're going to stabilize the shoulder blade, whereas the supraspinatus is attaching onto the humerus is going to stabilize the humerus and the ball and socket joint of that shoulder. So they want to be working together. But if you just focus on these little ones and you don't address these huge ones, you're going to create an imbalance. And there's no way that these little muscles are going to be compensate for these huge muscles. And if you've had a shoulder dislocation, if it's chronic, meaning more than twice, you know, I've worked with people who've had like 36 dislocations of the shoulder where they essentially they can just pop out, they can pop them back in. So really unstable. You have to get these muscles working really well. You have to. And then if you add in probably the most overlooked, two overlooked muscles in shoulder rehab is the lats. Latissimus dorsi and pec major. So if you're trying to address a chronic shoulder dislocation type scenario, and all you're doing is little internal and external rotations with TheraBand, stuff like that, you're going to get nowhere. You need to train these huge muscles. Look at this huge muscle, the pec major. Look at that huge tendon where it attaches onto the humerus. Even bigger muscle, latissimus dorsi, attaching pretty much in the same position. Lats on the anterior aspect, pecs kind of in the medial aspect. These muscles are both internal rotators, so they turn the humerus inward. Okay, so there's a balance between if you overtrain lats and chest, you're going to create internal rotation, which is going to put this muscle on stretch, which will weaken it over time. So if you don't train rhomboids and trapezius, as well as serratus anterior, you'll get this kind of shoulder, which is kind of pinned forward and internally rotated. So it'll be protracted and internally rotated and most likely slightly elevated, and that jammed everything up in here as well. So you have to address all these muscles. So what you need is essentially a program where you focus on chest, back, middle back, and trapezius. So that's going to be essentially a push, pull, shrug type program. And then a pull down type program through here. So the lats and lower traps work together in like a pull down. So you need the four planes of movement addressed: forward, back, push up, pull down. And that needs to be done with full range of movement of the shoulder blade. So you train the shoulder blade to move full range forward and back. If you do that properly, you will get these rotator cuff muscles engaging and firing. Now, the only reason they won't fire is if they've got a lot of adhesions, a lot of active trigger points, myofascial trigger points, some kind of inhibition that's affecting the neural drive of the muscles. So you may need a little bit of kind of ART, PNF, MFR, so some bit of manual therapy just to kind of make sure the tissue quality is good and get them firing, and then you can kind of start the rehab process. And then it's about working with somebody who understands where to start all that. Okay, what exercise do you start at, and then how do you progress and step on through? No different to if you're training in the gym and you're doing a strength program or a hypertrophy training program. It's like, where do you start somebody and how do you guide them, progress them through? So my work is at the kind of post-acute phase. So once inflammation is basically decreased, or if they come to you and they're quite acute, so they've just injured themselves, I'll help manage the inflammation, and then we go into the exercise rehabilitation phase, depending on what's going on. And in a chronic dislocation, it's going to be basically training the entire shoulder because the ligaments are lax, and you can't, once the ligaments are lax, that's done, they're done. The only way you can address that is if you have surgery. So outside of surgery, and the surgery they do, they often overcompensate, so they tighten everything up a lot and people lose mobility and stability. So if you can, try to avoid surgery unless it's really, really necessary, in my opinion. Okay, some people do need it. The problem is if you're chronically dislocating is you've got the brachial plexus coming out through here, and then you're going to keep impinging your brachial plexus. So if I put that in there, brachial. Dun, 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 dun. Left. Oh. So you've got all the nerves that are coming out of the neck, and they come underneath the collarbone and between the collarbone and ribs number 1 and 2, and then down through your axilla, your armpit. So if you get that kind of scenario where I mentioned before, where the humerus is internally rotated, it's protracted, and it's elevated, essentially the brachial plexus space through here gets compromised, and then you can compromise the nerve supply. So you can get compression on the nerves. So that interferes with the nerve supply coming down. So you can get issues anywhere down the arm, because essentially the brachial plexus supplies the entire arm, so right down to your fingers. So one of the big issues with chronic dislocation is if it's an anterior dislocation, the bone comes forward and then drops down, and it compresses the nerves here, and that can be incredibly painful. So you get a triple whammy, essentially. You get the connective tissue damage, so there's going to be some tearing of the ligaments. The joint capsule and the synovial capsule will be definitely hyperstretched, if not torn. And then you're going to get potentially some muscle strains as well, tendon strains, and then potentially a impingement of the nerve in the brachial plexus, which is pretty yuck. So if you get a really nasty shoulder dislocation, it can be pretty horrible. And if that's the case, you'll most likely need to go to hospital and have it reduced, surgically reduced. Because if it's done in the wrong way, you can create, if you try to put your shoulder back in, you can create a lot more damage with it. You can tear the tendons, potentially even, compromise nerve and blood supply through that, and can kind of get pretty nasty. And if with modern, like emergency medicine, they're pretty amazing. They can give you some amazing drugs and help you get that shoulder joint back in place. A good friend of mine, he managed to dislocate his shoulder and his knee at the same time. He was way out in the bush. It took him hours to get into the hospital, incredible pain, and they got him on, I think it was ketamine. And then from there on, he was okay. So modern medicine, emergency medicine is amazing at particularly at managing acute injury. But modern medicine is not so good at chronic disease processes at the moment. All right, but I digress. So that's the ligaments of the shoulder, and with a little bit more kind of detail with the muscular system, brachial plexus, and a couple of things to kind of consider with that. So remember, gentle mobility exercises are for the joint. So things like just stick drills, arm circles, gentle mobility exercises, gentle yoga, Tai Chi, Qigong are fantastic for mobility, because when you practice Tai Chi and Qigong, the goal is to stay really relaxed. And so you're still using muscular contraction, but the goal is to not overuse your muscular system. So you are relying on the fascial system and the connective tissue and the ligaments. And over time, those tissues actually get quite strong with those practices. So that can be really, really good as well. And I've definitely helped a couple of people rehab shoulders by teaching them very, very simple Tai Chi and Qigong exercises based on the principle of gentle movement. And then, of course, we'll definitely do a video in the future where we talk about Qi, or energy, and how that works in the body, and the energy flows, particularly which moving through connective tissue. So you want to restore the connective tissue. And that's, again, go back to your manual therapy. If you've got adhesions in the connective tissue and the muscle, so disorganization of the alignment, then the stream of potential, the flow of energy or electrons into the cells can be interrupted. So then you get what we call in Chinese medicine qi stagnation. And then essentially the mitochondria don't have enough electrical charge or voltage to generate the energy to do the work in the cell. And that's what pretty much all Chinese medicine is based on. Chinese martial arts, Qigong particularly. It's a really, really powerful practice if you can do it. So that's it for today's video, guys. Hope you enjoyed it. If you have any questions about the shoulder ligaments, please feel free to drop them in the comments below. Always happy to answer any comments you have. And we will see you in the next video. Wherever you are, stay curious, keep learning, keep training, be healthy, and have a great day.